Thank you for joining me for the WebEx on the new acute care eating disorder clinical decision support tool and pre-printed orders for adults and pediatrics. I'm Carla Mantie, and I'm a practice lead for mental health and substance use. And over the last couple of years, I have worked with groups of very passionate and motivated individuals to create the acute care eating disorder resources that we'll be talking about today. The decision to work on this project came from a realization from the acute care sector that services for this very complex population were lacking and admissions were long and complicated. There was no standardized process for admission, and management and provision of care was very inconsistent. Patients were ending up on different wards with differing knowledge and experience, and there appeared to be a general feeling of a lack of knowledge and experience with this population overall. The inconsistency in variance in practice led to delays in care, extended length of stays, confusion and frustration for patients, care providers, and staff, which ultimately led to poor outcomes for our patients. As we started this journey, we acknowledged that there was concerns and included many stakeholders along the way. We had leadership support and endorsement from the beginning, and an evidence-based decision support tool was the product. So let's start with what is an eating disorder. An eating disorder are serious and complex conditions that negatively impact every aspect of an individual's life. They're complex dysfunctions of the central nervous system involving neurochemical and structural differences in the brain that drive distorted thoughts, intense emotions, and maladaptive behaviors, which can improve with nutrition, emotion regulation skills, and validating environments. Eating disorders can involve a number of complications, and with more severe and long-lasting illnesses, they can be fatal. Due to a high level of ambivalence for change, lack of feelings of fulfillment or control, denial and fear of negative consequences experienced by people with eating disorders, treatment of the disorders can be very challenging. Inpatient care and treatment with a focus on medical stabilization is recommended for individuals with eating disorders who are at short or long-term risk of harm unless their medical complications are addressed immediately. Numerous factors and conditions influence patients' risk, including age of onset, rate and degree of weight loss, chronicity, ethnicity, comorbid conditions, and medication. So what we know about eating disorders. We know that often hospitalizations are lengthy and can last beyond the numbers. This means that a patient may appear medically stable, however may not be ready for discharge. They may be at risk for further medical destabilization due to aggressive refeeding protocols, or they may lack insight and or judgment to be able to manage eating on discharge. Good team communication and planning is imperative. Using the interdisciplinary team meetings to plan care can avoid setbacks and team frustration. Consistency in planning and implementing care is essential, especially prior to the interdisciplinary team meeting and or psychiatric consult. Meal supervision is the intervention, and food is the medicine. We know that for pediatrics, the admissions may be the first time they've needed intervention and the first time they ever may get a diagnosis. Pediatrics may have longer stays due to the inclusion of multiple members into the care planning and discharging process. Peds may require more admissions to be able to influence the pattern of the disorder and change behavior. Good treatment and early detection is the goal and can help to decrease possibility of readmission. To find the Eating Disorder Acute Care Toolkit on the Inside Net, you can type eating disorder into the search button, and it's the first two links that appear on the list. The toolkit can be found on the Mental Health and Substance Use Clinical Care Resources page or on Acute Care Find It. All of these should lead to the toolkit. It is recommended that admission packages be printed to prepare for an admission and resource binders be created to support staff quickly. As you can see, I have typed eating disorders into the search engine, and as I just push search, it's the first two links again that come up on the list. If you pick one of them, it brings you right to the Eating Disorders Toolkit where you'll find all the forms and guidelines that you'll need. So on the toolkit, one of the first links is the CDST. And so the standard of practice is that all patients with an eating disorder in need of medical stabilization will be admitted to a designated unit in a designated hospital and receive one-to-one added care for meal supervision throughout their admission. The designated hospitals and units will have the following minimum service provisions: physicians, pediatrician, or psychiatrist with expertise in eating disorder management, nursing, social work, and/or other allied health staff with a working knowledge of eating disorders, psychiatric and/or pediatric teams that can provide support and liaison to nursing staff, dietitian with expertise in eating disorders to implement and oversee the meals plan. All clinicians caring for patients with eating disorders must be competent to enact any care outlined in the CDST and practice within their scope of practice. It is preferable that admissions be planned in advance. However, we also recognize that this isn't always an option. When possible, the community teams, such as mental health and substance use, eating disorders programs, child and youth mental health, or the primary care physician, should contact the designated units when the potential for admission is looming. They would contact the PCC or patient care coordinator on the designated unit, as well as complete the planned admission form to discuss patient goals and needs. Site-specific processes should be used to plan for the admission, and notifications should be made to the dietitian, shift coordinator, and other relevant people on the team, such as the Aboriginal patient navigator or the hospitalist. An interdisciplinary team meeting should be planned as soon as possible, ideally before the admission, but at minimum, it should take place within 48 hours of the admission. The interdisciplinary team should include all relevant people from acute and community care, including, when appropriate, the patient and their family or care providers. Admit the patient to the designated unit and prepare the room and services. For example, when possible, select appropriate room location with consideration of the care plan requirements. Bathroom doors should remain locked at all times if possible. Remove garbage cans and bags from the bedside in the room. Remove or lock all sharps containers. Remove drinking cups, if possible. And the PCC should arrange one-to-one added care for meal supervision. When patients present to the ER or need urgent admission, the back of the PPO directs physicians regarding admission criteria that have been agreed upon by provincial experts. Admission processes should still occur, for example, the designated units and the interdisciplinary team meeting, etc. On admission, establish a relationship with the patient that is safe, accepting, confidential within the care team, reliable, and consistent with appropriate and clear boundaries. Effective treatment requires a balance between attending to the therapeutic alliance and clear boundaries to ensure patient safety. All admissions should be co-managed by medical and psychiatric personnel. Physicians initiate the PPO for adults and pediatrics, which clearly outlines care and interventions for the first 48 hours or until the interdisciplinary team can be arranged. Things of note on the PPO are dietary instructions related to supplementation, one-to-one care requirements for meal supervision, and when to contact the physician with concerns. It also notes labs, diagnostics, IV therapy, and medications. Complete a regular 48-6 nursing history and the addendum that guides the nursing questions specific to eating disorder behaviors and patterns. Please note suggested phrasing on the form and do not provide this form to the patient for them to complete themselves. During the admission, assess for acute psychiatric crisis such as suicide, depression, psychosis, and self-harm. An eating disorder cardex has been created to support daily communication and documentation. However, it's optional for adults and pediatrics. A quick reference guide is a more detailed reference for all the specific interventions needed to support these patients. For example, the reference guide details such things as removing meal trays, tickets, and packaging, keeping blankets below the face and hands, and removing access to all cell phones and social media. Initiate the 24-hour care flow sheet for adults and the PEWS forms for peds. The 24-hour flow sheet is a combination of the current medical and psychiatric forms to ensure that relevant data is being assessed and collected daily for our patients. In regards to medical management, the key physical assessment parameters and action points are all located on the appendixes within the CDST. There's always points to assess as well as actions to take. For behavioral management, ongoing interdisciplinary team meetings are an essential part of the care for these patients. Meetings should occur weekly at a minimum, and it is best to schedule them at the same time each week so team members can plan to attend. Participants should include the primary care physician, psychiatrists, hospitalists, nurses, care aides, social workers, PCCs, and other allied health as relevant to the care of this patient. If appropriate, the patient and care provider should be included in at least part of the meeting. Interdisciplinary team meetings are a chance for everyone to get on the same page, discuss concerns and milestones, as well as a great opportunity for team education and support. This is an extremely complex patient population, and solid team approach is essential. The approach with patients is extremely important and as much as part of the medicine as food is. It is important to be firm, supportive, non-judgmental, trauma-informed, and culturally competent and safe. Care providers and significant others should be actively engaged, supported, and respected without making assumptions about the role in the development of the disorder. The plan of care is individualized for each patient in relation to their medical condition, comorbidities, emotional readiness, and supports available, and must be updated after every interdisciplinary team meeting or as needed. The individualized plan of care should include progressions related to nutrition, elimination, medical monitoring, activity level, level of monitoring or supervision needed, family and or other support involvement, passes, and other areas as appropriate. It should include clearly documented expectations and management of specific weight loss behaviors. Again, meal support is the intervention to be used. It includes knowing supplementation guidelines, supervision expectations, and assessing for weight loss behaviors. Meals need to be supervised 30 minutes for a meal and 20 minutes for a snack. And supervision must continue for 60 minutes post-meal and 30 minutes post-snack. To support the clinicians providing meal supervision, the Acute Care Meal Support Resource can be utilized. It explains key interventions and provides examples of language to be used. These can also help to educate and support families and care providers. Weighing patients can be a difficult time and a time of much anxiety and frustration. A firm, caring approach is necessary. Weigh patients in underclothes and hospital gowns or personal pajamas only, with a back to the scale and at the same time in the morning, before breakfast, and after emptying the bladder. Restrict patient access to the scales between weigh-ins. Do not disclose the weight to the patient or engage in discussions about weight. For privileges, careful consideration should be given before permitting passes and the use of cell phones or other social media or electronic devices. They all should be removed at first and then discussed at the IDT as to when to be reintroduced. The interdisciplinary team meeting can decide progressions of privileges. Any violent and or disturbing behavior should be discussed, and additional actions or resources may be required. Be aware of splitting and triangulation, as this can result in team frustration. Transfer and discharge. Admissions should be kept as short as possible. However, we know that this population tends to have a longer length of stay in acute care. Every time the interdisciplinary team meets, including the first week of admission, the process of discharge planning should be discussed. If the patient's clinical concerns are not resolving, it may be appropriate to transfer the patient to a specialized unit or to a higher level of care. The transfer should be communicated and planned with the other unit or facility, and all transfer procedures followed. It may make sense for the MRP to transfer from a medical family physician or hospitalist to the psychiatrist, even though the patient may remain on a medical unit. This should be discussed on a case-by-case basis and planned through site-specific procedures. Consultation with the tertiary specialist eating disorder team is encouraged if the patient is not improving. St. Paul's Hospital or BC Children's Hospital are our eating disorder programs in the province. Thank you for joining me today, and I encourage you to take a look at the toolkit, familiarize yourself with the resources, and ask any questions you may have. If you have any questions, please don't hesitate to contact me at the numbers listed.